Well, hi again, folks, and welcome into Health Talk Mississippi. I'm Greg Flynn, your host, and this podcast is brought to you by the Mississippi State Department of Health, and we try to bring you topics that you may not normally think about. We try to educate, inform, and entertain you all at the same time. So we hope you enjoy this episode, which we are going to delve into the world of opioids and the abuses and what can be done about that for people that do get hooked. Joining us today is our director of our MSUD program, is Dr. Jon Hubanks, and welcome, Doc.
Thank you, Craig. It's good to be here.
Well, if you can, one of the questions, we hear it all the time. You hear what opioid abuse, you hear opioids this, opioids that. What exactly is an opioid?
Well, opioids are made up of naturally occurring products and synthetic products, man-made. So you have these that are made for prescription treatment of pain in general, and they're very effective when used appropriately. So when you use the word opioid, it can refer to many different things. It can refer to something as simple as a prescription that you get filled to treat any type of moderate to severe pain, all the way to an illicit synthetic substance, which is what you think of when you hear fentanyl, even though there are versions of fentanyl which are medically approved uses for. So I always try to avoid saying, fentanyl when describing an illicit opioid, because fentanyl does have its a good use and appropriate use in medical settings.
Well, it's you have the legal side of it, which are the prescription meds, and then you do have the illegal, which you can get on the streets. How do you differentiate between the two?
Well, it's very difficult. There are test strips available, and that you can get in Mississippi now, and that will test for fentanyl in any product that you have. You just dissolve a little bit of the product in water, dip the test strip in there, and tells you if it's positive for fentanyl or not. So those were criminalized. They were in statute as a paraphernalia, but those are no longer in statute as paraphernalia now. So we are able to provide those to citizens across the state to be able to test. And that's the big concern when it comes to illicit fentanyl or counterfeit pills that are laced with illicit fentanyl, because someone may think they're buying an Adderall to help study and get through final exams or something, but it may be laced with fentanyl, and you start seeing overdose spikes because it's people who aren't tolerant of an opioid, and fentanyl is highly potent, so it does have a tendency to cause overdoses quite easily.
And I think immediately when we hear an opioid overdose or an opioid problem, you think of illegal drug users. But I think that when you talked about that is for prescription to help people with pain, post-surgery or things like that, that's where you can actually become addicted, and people don't even know it until they just keep wanting more and more of it. Is that true?
That is correct, yes. And you do see cases where people started taking an opioid. A good example I like to use is, say, a high school or college athlete that injures themselves. So they're injured, they're out from playing, they start taking an opioid that's been prescribed by the doctor. Not only is it helping with their physical pain, but the emotional or psychological pain they're feeling from being out for the season and not able to play, it numbs that pain as well. So you begin to develop not only a physical dependence, but a psychological dependence as well. So you do see cases like that. Thankfully, through education, those are not as prevalent as they used to be, but that is the case in some instances.
Is that the reason why I think that some physicians are hesitant a lot of times to prescribe or keep refilling somebody's painkiller medication?
You're exactly right. And that has been through lots of education. Early on, physicians were being told by drug reps, others, that, you can prescribe this as extended release. It doesn't create the dependence or the addiction like some of the fast-acting opioids would. However, that just wasn't the case.
Well, I know that, and if you guys are interested in listening to the podcast to talk about opioids, you can go to the Mississippi State Department of Health website, and you can see the opioid and prescription drug abuse page. And, it says here that, it really took off in the 1990s, in the late 90s, where opioids we had so many overdoses that were occurring, as you just mentioned. The doctors were like, okay, I'll keep refilling people's stuff. The good news is we've seen a steady decline in the opioid overdose deaths.
We have. We actually, especially when it comes to prescription opioids, there's been a significant decline, and that's been due to education. Where we have seen over the past 5 years was sharp increases in overdoses due to synthetic opioids being more illicit fentanyl. And thankfully now we're seeing all of those on the decline. We had a spike, we spiked at the highest in 2021 and since have had a steady decline. In 2021, we were 19th lowest in the nation for all drug overdoses. And as of end of 2024, we were down to 12th lowest. So we've made a pretty significant decline in overdose deaths within the state.
Do you think we saw that big spike in 2021 where it looks like we went for the fatal overdoses? We went from 586 in 2020 to 788 in 2021. Is any of that, what do you attribute that to? Did the pandemic contribute to any of that?
I would say yes. I think it was like the perfect storm. So that's around a little before that, you really started seeing the illicit fentanyl getting put into counterfeit pressed pills. So those really spiked around the same time as you were seeing everything being shut down due to COVID. And people were at home and they were numbing pains that they were feeling and being socially isolated. And the way they would numb that would be through recreational drug use. And then you start seeing these numbers just climbing and climbing of overdose deaths, unfortunately.
Well, I see here that unfortunately, this is kind of like the younger age demographic that we're talking about too. That people under age 35 are the most fatal deaths.
And again, there is the shift with the illicit fentanyl making it into the local drug supply. That's when you started getting the counterfeit Adderalls, counterfeit Xanax that were being pressed by drug dealers, for lack of better terminology, that were using fentanyl as fillers in those medications and pushing them off as legitimate prescription medications, and they weren't. So you see that decline because it's that age group that's more likely to get a Adderall, air quotes there, Adderall from a friend and not say, well, where did this come from? But that friend got it from a friend, and really no one knows the origin of it. It didn't actually come from a pharmacy.
Well, you've been doing some great work at the Department of Health in our Opioid and Substance Use Disorder Program, affectionately known as MSUD. And that's really taken a big bite out of the opioid deaths, I think, right?
Well, we certainly hope that that's been a driver. We haven't been able to make direct correlations, but we've been doing a lot of hard work in prevention and treatment, and hopefully that's really driving our numbers down.
So if you walk us through, so somebody reaches out to you all, because that's the most predominant way they can reach out. How does somebody get started in the program? How does that work?
Well, so we have different components in the program, and I'll skip to treatment just a minute. We have a surveillance, because to understand how the full program works, you have to understand the different components within the program. So we have a surveillance arm, which really looks at the data, looks at what populations are being affected, age, race, everything you can think of, which gives us the data to drive prevention and response efforts, where they are geographically, all of that. Then prevention being the part where we're working with naloxone education, all of these things to keep people alive. Then that gives us the time and the opportunity to get them engaged in treatment. So treatment is kind of that third arm, that a pillar, if you will, of the program. And yes, anyone can be referred to us, either self-referral, referred by a friend or family, another provider, a community mental health center. There's a referral form that they just complete, and then that gets sent to a navigator that's within the program who either has lived experience or is familiar with the program. They do a They basically get the information. They fill out a red cap form. It comes in and divided up north, central, southern part of the state. One of the navigators, depending on the part of the state they're in, reaches out to the individual, does a verbal assessment to determine if they're appropriate for our program. And once they are determined as being appropriate, they schedule the appointment, their initial appointment. We have 75 county health departments that are serving the state through providing opioid use disorder treatment via telehealth. So they schedule them at their most convenient county health department based on their location, where they can see a nurse practitioner or physician via telehealth and prescribed medications to treat their opioid use disorder.
And how do you treat a disorder?
So there are several different ways, but medically, through medication, there are different medications that you can take, and the clinician determines which is most appropriate based upon your usage history, so on and so forth. That treats the actual physiological craving part of an addiction. So you immediately stop having withdrawal symptoms, and you stop having the cravings. So that allows your body to adjust based upon what you've been taking. Then there's the psychological aspect of it, which is the mental health part. So you need to also have a behavioral health component depending on how severe the addiction is. And that it will give you the psychological support. We also have peer support specialists who help patients navigate their way back into recovery from where they are.
Well, I know that our MSUD program, it's not just, well, you sign up and then, well, if you show up, you show up. No, you guys actually continually follow up with these folks, right?
Yes. We don't take the most intensive patients, so they determine on your level of care need. You may be appropriate for what our program is an office-based outpatient treatment program. Depending on your severity of addiction, it may be that you need to do an intensive outpatient treatment or residential treatment program. There's different levels, but through that conversation with the navigator that first connects with them, they determine if they're eligible for our program or not. But what makes us, I guess, a little different in that sense is that if someone is determined not appropriate for our lowest level of care, they work with community partners and others who provide more intensive services and get them connected to those entities and make sure that they either get into a residential facility or into an intensive outpatient program as needed.
Well, what I like is that you deal with it not just on the opioid level of them taking but you focus on that mental health, and I think that is so important for people to understand that that's just as important as solving the addiction itself.
That's a key component of solving the addiction, and what it really takes a little diving into, and I won't go deep into it, of understanding how addiction works, because your brain is a great organ that we have, and as you introduce substances to your body, it goes through this process of neuroplasticity. And to break that down a little bit, what neuroplasticity is, you can think of like the woods behind your house. The first time you go walk through the woods, if there's not a path there, you have to push grass aside, brush aside. You have to create a path. But if you're walking that path then every day, it becomes smoother and wider and easy to travel. That's what happens in our brain. So as you are taking an opioid, for example, those pathways diverge and become smoother and wider based on your behaviors. And so that creates these new pathways that avoid things like stressors and outside things that you're trying to avoid and trying to avoid dealing with.
Well, it sounds like it's kind of just like an alcohol type addiction, that it's treated the same way, that you have to help get that person to not have the urge, but then not only not have the urge, but for longer term is to teach them not to fall back into that, right?
That's exactly right, yes. And it's easier to break ground and build that new path through the woods than it is to have the grass grow back up and fill back in and start using an old path. So that's what takes time. And the medications reduce those cravings, and it allows you that time for that grass to regrow, if you will, in that path that you've plowed through, and allows your brain to revert back to the original pathways that were there.
Well, and it's tough because with any kind of addiction, many times the person that is suffering from the addiction says, "Oh, I don't have a problem. I'm just fine." How do you encourage them, or is that where you talk about the third party referral, family or friends that want to get them help?
So that is where you create opportunities for engagement, and not every opportunity someone's going to be ready. But that is one thing where naloxone, that before the show started, we briefly touched on why it's vitally important, because what you want to do is keep these individuals alive long enough to get them engaged in treatment. So the first time, it may not be the right time. Second time, it may not be the right time. But eventually there will be a right time when that person feels like it's time for me to get some help. And so those critical touch points of when they have experienced an overdose are vitally important to be able to get people engaged in care at the most appropriate time.
Well, the naloxone has been a hot topic out there. So because they're offering it basically for free from pharmacists. Heck, I've even seen vending machines have been set up in some locations. I know we have one that got set up in the Jackson Medical Mall here in central Mississippi, that everybody should have some, that you should keep them. That blew my mind. Kind of explain to our audience why everybody should have some Narcan or naloxone available to them.
So when you go back several years, I mean, there were many communities around Mississippi who had little to no access to naloxone, which is a life-saving medication for an opioid overdose, because it was prescription product only, and they were only able to get it in a clinical setting. So what we did at the MSDH, since we have a pharmacy at the MSDH, and there was the standing order that was available, is people could request naloxone. It would go to the pharmacy. The pharmacist would do the standing order, would write a prescription, and fulfill a naloxone kit, send it out to people through the mail. They usually get it next day via FedEx or UPS, sometimes up to 3 days. We started that way because it was still a prescription. Then there was the shift to over-the-counter, and so that's when you really started to see a surge in naloxone being available in communities. And there's a lot of talk about naloxone saturation, and that's really where we were a few years ago, back in 2021, when we had the spikes. Naloxone was still a prescription product. There weren't many places to access it outside of a clinical setting, and there were many communities, if there wasn't a clinical setting or it was after hours, they couldn't have access to it. So the OTC product then allowed us to even further distribute more naloxone to community-based organizations for further redistribution and training in communities. So the goal really was to saturate communities with naloxone to provide opportunities to keep these individuals alive, to be able to work those opportunities to get them into recovery.
What exactly does the naloxone do?
So when you take an opioid, it binds to a receptor in your body called an opioid receptor. And when you use naloxone, it goes in and it has a stronger affinity for those receptors. So it displaces that opioid from those opioid receptors. And when you take an opioid, it slows your breathing, which can lead to, respiratory failure, heart attack, those kind of things. So when it displaces that, it reverses that, allows you to start breathing again, allows your heart to begin working as it should again, because not everything is being slowed down by the opioid and suppressed.
But it's still important that even when you start to feel better, you come back out of the throes of death, that you still need to go get medical treatment immediately,
Absolutely.
Right?
Yes, absolutely. All that is doing is buying time. It has about a 60 to 90 minute life once you administer it. So you should, if you administer it to someone, you do call 911, you stay there with that individual, because there is the potential for them to need another dose of it. And so you do want to still contact emergency medical services. So it gives you that critical time from when they go down and when EMS can arrive to provide further care.
So I think when you talk about that, everybody should have some. It's not only for if you have somebody that's an abuser of opioids for yourself that you know within your circle there, whether it's family or friends, but it's also, we talked about if you're out in the public and you see someone in distress, that you find out that it could be an overdose, you can help save a life.
Absolutely. I mean, there's no harm in administering naloxone, whether you know that person has taken an opioid or you don't know. If it's just someone that you just see that falls out in a restaurant, it's not going to hurt them if you administer naloxone at all. But you're still going to call 911. You're still going to do all the other normal things. But naloxone is that product that will allow you to potentially save their life if it is due to an opioid.
One, I think it was a game changer when you educated first responders to the great advancements of using naloxone. And you see fire departments, you see police departments that have it because they're typically first on scene, many times before an ambulance crew. So getting that out to those responders and getting them to recognize what's going on has undoubtedly saved lives.
Oh, it does, yes. And one thing that we tried to educate and do in that whole conversation of first responder is when anyone thinks of first responder, they automatically think firefighter, law enforcement, paramedic, whomever it may be. But what we have attempted to do is shift that focus of first responder to the first person who sees someone go down. So with naloxone, anyone becomes the first responder if they have naloxone in those instances. And so anyone can save a life until your traditional first responder actually can arrive and provide the medical need.
Are you seeing more in trend-wise? Is it still currently predominantly street drugs that are hooking people, or have we gotten past the prescription abuses of an opioid?
So you do still see prescription abuses of opioids, but it is predominantly recreational use or having those who started off using a prescription opioid no longer have access to it, start buying something from the street that's been laced with fentanyl. They build up a tolerance to fentanyl. That's really what you see most often now.
I think it's fascinating. You go to our website and you can see what to do in case of an overdose. And certainly the first thing you do is call 911, get somebody rolling that's going to be able to help. You tell folks never to be afraid to call, even if you are overdosing or doing drugs. They're not going to judge you at that moment. They just want to help save your life, right?
That's correct. Yeah. We have the I don't remember the name of the exact act, Opioid Response Act, I believe, but it basically is you're not going to be charged with
a crime
unless you have an intent to sell.
Yeah.
If you just have a small amount that you've personally used or someone with you has personally used and overdose, they're not going to make you go to jail.
I think some of the interesting ones here are the what not to do's that you can see. What not to do. So the first one is do not try to wake someone from an overdose by slapping or hitting them. It'll only cause further injury. If you cannot wake the person by shouting, try rubbing your knuckles on the center of their chest or light pinching them. And then it says, do not force liquids into the person. Don't try and dilute it yourself by pumping them full of water, or I guess that's been tried before.
I suppose, but my first thought is it goes to if they're out asphyxiation. You don't want to cause more harm.
Do not put them in the cold bath or a shower. That would increase the risk of falling, drowning, or sending them into shock.
Yes.
It's a good one. Do not try to make the person vomit drugs that they may have swallowed. Choking or inhaling vomit into the lungs can cause a fatal injury. That's a big one because a lot of times you'll try and get them to throw up.
Right.
You want them to try and throw up to get it out, but it's probably too late at that point, right?
Right. Again, asphyxiation. You don't want to cause more harm.
Never leave the person alone to sleep it off.
Right.
Because they may not wake up.
Exactly.
They may go to sleep, but they may not wake up. And then the last one is very important. It's, as you just covered a little bit, don't lie to the emergency, to the responders. Give them the complete and accurate information so they can give the best help right away. That's not the time to be keeping secrets and being worried about getting arrested or charged with something, right?
That's right.
Well, I think this is fascinating, absolutely fascinating. And I'm glad to see for the third third year in a row we've seen a decline in opioid deaths here in the state of Mississippi.
From 22, 23, 24, and 25 are all 25 still provisional, but yes, we went from, as you said a few minutes ago, I believe it was 758, if my memory serves me correct, in 2021.
Yeah, 2021 was mid 700s.
787. Then 2022 was 758, 23 702, 24 532, and provisional 25 is 308.
Well, and I'm glad to see that all of the state agencies are taking this seriously. We just had the big opioid settlement because big pharma was pushing the opioids at the time, and now they got to pay the price.
Correct.
And we have a good plan in place because we have an opioid advisory council that's led by our Attorney General Lynn Fitch, and our very own Dr. Edney, the state health officer, is a vice chairman on that committee, and they are finding ways statewide to be able to get more help and more education out to people. So that's got to be heartening to you.
Oh, yeah, absolutely. I mean, it's what you saw with lots of applications that came in for opioid settlement money is there is a real drive for community organizations and healthcare providers to really be able to treat this population. I mean, that's where most of the money that's being allocated is to provide treatment and to build that road to recovery for this population of people.
Dr. Edney loves to talk about this. This is a preventable death.
Oh, yes.
These are all preventable deaths we're talking about here. And he says that's the number one thing that we can put our foot on the neck of, our preventable deaths in Mississippi, and it would increase our population. It would create increased families. It would just have second-order effects that are mind-blowing. But being able to prevent this is easier said than done, though.
That is correct. There's many barriers to this, from being cultural and local areas and even national level. So that, just to give you a few examples from national level, there's been a pull away from using the term harm reduction. Harm reduction, all we're essentially saying when you hear the word harm reduction is things like naloxone, fentanyl test strips, things that we can do to keep someone alive, to provide that opportunity to get treatment and get on that path to recovery. That's harm reduction in a nutshell. So that's something from a broader perspective. But then when you get down into Mississippi specific, stigma is another. It's gotten better. But it used to be where someone would not want to go to a treatment facility that specialized in substance use disorders because they didn't want to be seen going to a facility that is known for treating a substance use disorder.
Especially small towns where everybody knows everybody.
They didn't want their neighbors to see them. So it's getting people aware and introducing this whole concept of an addiction is not something that someone asks for. It is actually a chronic condition, and like you said, it's a preventable death. So it's important. So we just to jump on something on the stigma reduction, we are planning and hope to have by fall a couple of stigma reduction summits, one focused on educating communities and the lay individual who doesn't know a lot about substance use disorder but has an interest in knowing more about it, and one more geared toward healthcare professionals, first responders, clinical type settings.
One of the things I think is very important to point out is that our county health departments are there to help. They can give you the initial information and get them in contact with the folks in your program. And that may take some of the stigma away because you're not going to your primary care physician. You're not going to a treatment center. You could be going to the health department for anything.
Correct.
So you could walk into the county health department that's closest to you and have a conversation with somebody that doesn't necessarily know you, perhaps, and nobody will know what you're there for.
So we took a couple approaches on that, and that's why we actually built an online request form where someone could request treatment. So you don't have to go into a clinic. You can do it from your phone in the comfort of your living room. You don't have to face the stigma with requesting help. That was one thing. With our peer navigators, people who either have lived experience or have worked with substance use disorders for years and have a passion for the work, who don't use stigmatizing language and don't shun anyone that's seeking treatment. But we also, another large initiative of that is working with the University of Mississippi Medical Center Emergency Department. So one of the physicians there has a huge interest in what is an OEND, which is Opioid Education, Naloxone Distribution Program. So when anyone comes in to the emergency department at UMC, they are screened as whether they may have a substance use disorder, and if identified, they're provided opioid education and offered naloxone bedside counseling. And if they are ready for actually engaging in treatment, the physician, they have protocols in place to write prescriptions for their medications to start them on a medication for opioid use disorder, and then link them to care with the MSDH treatment program or another program in the state that they're appropriate for.
Well, I think that's fantastic, and I'm glad you pointed that out, because you can take that online route and nobody needs to know. You don't even have to talk to somebody until they follow up with you. And I would encourage everyone, go to the Mississippi State Department of Health website at msdh.ms.gov, and you can get there quickly by just typing opioids into the search bar, or you can go under health and safety and then go to the opioids and substance abuse section, which has so many resources, so much information. Kudos to your team for filling that page with so many resources for people.
We also developed, not to take away from the MSDH website, but an overdose-specific website to not take away from, but complement MSDH website, so odfree.org. And the same form is located there for accessing treatment, for requesting naloxone, for getting more information about substance use disorders, and anything that you may have a question about or want to know more about, you can find at the Mississippi State Department of Health website, and it's also found on odfree.org.
Very good. Dr. Jon Hubanks, thank you so much. It was an enlightening conversation. I think a lot of people understand this problem a little more clearly now.
Yeah, I think we're making strides, and I think that anything that we can do to help people understand, we're willing to do. There may be a town hall request form on odfree.org where we are beginning to start up and try to have more town hall conversations on opioids to inform communities. So if that's something anyone's interested in, that information is on odfree.org as well.
All right. Well, Doc, thanks for coming in today.
Thank you. I appreciate it so much.
You got it. Well, that's going to do it for this edition of Health Talk Mississippi. I'm Greg Flynn, your host, and we will talk to you again soon.